Good afternoon. We're live. It's Thursday, September 10th, 2020, and this is the bi-weekly Healthcare Provider webinar presented by the New York State Department of Health here in Albany. I'm Dr. Liz Dufour, Medical Director in the Division of Epidemiology at the State Department of Health. Joining us this week to update healthcare providers with our latest guidance in COVID-19 is Dr. Marcus Friedrich and Dr. Louis Snitkoff. Due to the large amount of interest in our bi-weekly COVID-19 guidance updates, we are offering a few different ways to listen to this webinar live and on demand. The audio and slide deck can be seen on YouTube Live. Point your web browser to coronavirus.health.ny.gov/weekly-healthcare-provider-update. The YouTube Live player is on our Healthcare Providers webpage. It's mobile friendly, so you can watch right on your smartphone or tablet. An on-demand version of the webinar is available via YouTube. Go to coronavirus.health.ny.gov, click on the Providers link at the top of the page, and then click on Weekly Healthcare Provider Update, and it's available immediately after the live webinar concludes. We're happy to be back talking to you all today after it's been a few weeks at the end of the summer with a cancellation, and we're happy to be back today as we start and enter into the fall. The agenda for today is packed as usual with updates on global, national, and New York State case counts, testing updates, updates on schools and colleges and universities, community mitigation and reopening, travel advisory updates, preparations for influenza and COVID co-circulation, healthcare provider wellness brief updates, and resources with a question and answer session at the end. Here's the link where the recordings will be available immediately after the live webinar concludes. And in addition to YouTube, an on-demand version of our weekly sessions for healthcare providers is available as a podcast. You can search NYSDOH. So let's take a quick look at the global summary. So we are now cumulatively globally at nearly 27 million COVID cases and nearly 900,000 deaths reported to the WHO to date. We have over 1.8 million new cases globally and 37,000 new deaths globally for the week reported ending September 6th. This is a 5% increase in the number of cases and a 2% decrease in the number of deaths compared to the prior week. As you can see here on the bottom row, the Americas still account for over half of the global cases and over half of the global fatalities. Here is a visual representation of the burden in each of the WHO regions, and we see that the Americas continues to carry a large burden here with the yellow-orange color. And they've added a line indicating deaths for the global rates, global counts for fatalities. Also, the WHO has recently been able to provide epidemic curves by region, and these are interesting to look at to get a sense of the way that the outbreak has rolled out in different regions. We see on the left here in the green color is the number of cases in Europe over time. The middle chart is Southeast Asia, and the chart on the right is and upper right is the Americas. We see that they've added a line for the number of deaths. Please note, a very important note here is that the scales for each region are different. So you'll see that the Americas scale for case counts is significantly higher, and the scale for death numbers is significantly higher than in the Southeast Asian chart. You can also see here, though, the patterns which vary and can give us a sense of different patterns in different areas. We see in the European epidemic curve almost two peaks here with an early peak and then a decrease and now some rise in cases later. However, the death rates have continued to remain lower in the second peak. In Southeast Asia, we see a rise from the earlier days in both cases and death rates, but again, and fatalities. But again, please note that the scales are different here. And we see here on the right in the Americas are sustained high levels of case counts and fatalities. In the Americas, the United States and Brazil continue to account for nearly 3/4 of the cases throughout the Americas. So what do we see here in the U.S.? In the U.S., we now have over 6 million cases and almost 200,000 fatalities. And we see over 260,000 cases in this last 7 days alone. This map is a picture of the cumulative number of cases by state. We see here that we are no longer in that highest case count category here. On the next page, you'll see what the color gradation looks like for the last 7 days. Again, we are even less darkly graded here. And finally, by case rate, taking population into consideration, again, less darkly colored here. So we have certainly made a lot of progress in New York State, but need to remain vigilant. Here's the epidemic curve for the U.S. Again, we see the picture of the case counts that we've heard about. Many of you have heard about throughout the lay press reports of the early peak, primarily in the Northeast and New York State, and then the second larger peak nationally. There's a new feature on the CDC webpage where you can look at different states and compare them. So in this screenshot here, the comparison is between California, Florida, Georgia, Texas, New York State outside of New York City, and New York City. And you'll see that the two lines at the bottom there are the New York numbers there. And this is by rate. So this is new cases per 100,000 over time. And so you'll see here that we have really maintained consistent low rates in New York State, in particular, compared to these other states of concern. And now brief updates in the New York State picture. So we are now at almost 9 million total occasions where individual New Yorkers were tested for COVID. And we are still holding at over 60,000 tests performed on average on a daily basis. We see that the total instances of individuals testing positive is now over 440,000. And we are remaining pretty consistent with new daily positives in the about 500 to 600 to 700 range daily, with the most recent one listed here from September 8th at 576 statewide. This visual does a nice job of capturing the continued high rates of testing offered throughout New York State and the continued low rates of positivity on testing, despite the gradual and continued reopening in various sectors. And on the right, we see here that thankfully total fatalities has not increased significantly over recent times, and we're still at over 25,300. For healthcare utilization, we continue to see low rates of COVID-associated hospitalizations, ICU admissions, and intubations related to COVID. Currently, hospitalizations for COVID are at 482. This is a slight uptick from the day prior by 19, but it's really remained pretty consistent at around this number, with newly hospitalized being 48. Currently in the ICU, 120, which is a decrease by 1, and intubations 55, a decrease by 4. Again, these are remaining consistent. Low, although we will keep an eye on that hospitalization number, of course. And cumulative discharges is over 75,500 COVID-related admissions subsequently discharged. So now for some brief SARS-CoV testing updates. So a new update for today. We know that one of the challenges for all of you as healthcare providers is the expected turnaround times for testing. And despite extensive efforts statewide to improve availability, it can still be a challenge given the need, particularly as we reopen colleges and universities and schools where we really have an urgent need for as quick turnaround times as possible. To assist healthcare providers with this, we have developed our public health laboratory. The Wadsworth Center has developed a list of laboratories who self-report to the Wadsworth Center having excess SARS-CoV diagnostic testing capacity. So that would be molecular testing or antigen testing capacity with a turnaround time of less than 4 days. And some of these of note have turnaround times of 1 to 2 days. The survey will generally be updated on Mondays of each week. And if anyone is interested in using one of these labs, it's recommended to contact them directly, and the contact information is available on the website. This slide contains a link here for the website, and here's a screenshot of what that will look like. Some other lab updates, as we have tried to ensure that we contain any cases, particularly in congregate settings, such as in workplaces or schools or colleges or universities. It's critically important to get the positive results to public health as quickly as possible. And some of that is the turnaround time as mentioned. And some of that is ensuring that we fill out the information when we as healthcare providers are ordering a lab, that we fill out as much information and as accurate information as possible. We're used to filling out the full name and date of birth, of course, and that's routine, and that's typically in the past all we would really focus on here. But it's very important for contact tracing efforts to also fill out an accurate address and an accurate phone number where this individual can be reached. And importantly, in colleges and universities, it's critical to fill out the address where they are currently residing or living. So if they normally live in Nassau County and they come to SUNY Albany for college and they are living off campus or on campus for their university experience, then that would be the address to list on the lab requisition form. And when reporting any positives, even if their permanent address or the address listed with their insurance might be at their parents' home location in Nassau County. So fill out the address where they're currently residing or living. Thankfully, part of an improvement is more availability of point-of-care testing. Molecular and more commonly rapid antigen testing is becoming more available in point-of-care opportunities. And the rapidity and the availability are really critical to helping us in ascertaining a student or individual's test status as quickly as possible. Again, though, please note that using point-of-care tests, remember that all COVID rapid point-of-care tests need to be reported to public health as well. So typically when a healthcare provider is part of a large system and that clinical lab is performing the test, or if your system sends to a large commercial lab, those labs are quite accustomed to reporting electronically to public health any reportable diseases such as COVID-19. And in COVID-19, the cases, both positive and negative results are reported. However, using point-of-care tests, there is not as much of an easy precedent with that being done in the past. However, with this disease and trying to contain this disease in New York State, it's absolutely critical that public health gets this information. So point-of-care tests, molecular or rapid antigen tests, must also be reported to the New York State Department of Health electronic laboratory reporting system. That information goes straight to the local health departments and the New York State Department of Health to report those cases, those test results, I should say. On this slide, we see the help desk for instructions on how to initiate electronic reporting. The phone number is 866-325-7743, or the email address eclairs@health.ny.gov is listed here. Please note we've had a lot of questions about an executive order signed by the governor yesterday on September 9th on this very topic, which further solidifies this legally. So the executive order is laid out here in simple terms. The executive order requires immediate reporting within 3 hours of results of COVID-19 or influenza testing by laboratories or point-of-care testing in a physician office laboratory via the New York State Department of Health ECLAIRS, or Electronic Clinical Lab Reporting System, when a result is received. Again, information required includes information on whether the individual patient is a student, what school they attend, and employment location if the person works or volunteers in a school or other sensitive location. Additionally, again, emphasizing that local address be inputted if it's different from their permanent address, but that's where they're currently residing. And this was just put out yesterday and signed yesterday. So you may need to discuss with your lab or with your health system and health setup and your site the best approaches to reporting this into ECLAIRS to achieve this directive. Note that all combined tests for COVID and influenza follow these rules for COVID as well. And again, here is listed the phone number and email address to get these instructions. The executive order also included directives for other entities, but for your awareness, I would like to review these briefly. So local health departments are required to report to the state daily any testing or diagnosis of a person who is a student, teacher, school employee, or school volunteer. Additionally, schools and school districts must report daily all COVID testing and diagnoses among students, teaching staff, and any other employees or volunteers affiliated with the school or school district. And higher education, colleges, universities, post-secondary education entities, all must, including a graduate school, medical schools, all must report testing and diagnoses daily to the state health department on any of these individuals, with additional notification if the total positive cases are 100 or over. Again, why does this matter? The entire contact tracing initiative to contain COVID really does rely on understanding who is positive, who is not positive, and really then aggressively containing through identification of contacts and quarantining those contacts. And so this is critically important. Also critically important, however, even with the best turnaround times, there will be a lag unless it's a rapid test until that result is back. So it's critically important to tell your patients when they are tested for COVID-19 to stay in isolation while awaiting test results. And we have some flyers here available to you to assist with this that you can email or hand out to them to assist. This one is available to you, titled COVID Testing Next Steps. This is a one-page flyer that can be emailed or handed out to patients. It's also available in Spanish. The link on the slide brings you to the location where this is available on our webpage, and you can print this. Alternatively, on the next slide, you'll see an email to request printed color copies that can be mailed to you free of charge. This COVID Testing Next Steps flyer delineates for individuals that if they are being tested due to symptoms, they have to isolate until that result is back. If they are being tested due to contact with a known case, they need to stay on quarantine. And whether that result is positive or negative, they are still on quarantine for 14 days after last exposure. The test result does not change the quarantine. It just merely helps identify if further contacts of that individual need to be identified. And there's instructions on, simple instructions on how to isolate and quarantine on the back of the flyer. There's also available, and here's the email address to order any of these materials from the New York State Department of Health, bmcc@health.ny.gov. And here are a couple contact tracing tools that can be given to patients as well when they are being tested to get them thinking about who they've been in contact with before they might forget that while they're awaiting their test result. They can pre-fill that flyer and be ready for when the local health department calls them. And this is a flyer that they can share with their contacts to tell those contacts to expect a phone call and to pick up the phone when they receive a phone call from this number. Now to briefly move on to community mitigation and reopening strategies. The major update since our last webinar is that New York City, as of yesterday, is now allowing indoor dining. The governor's executive order, as of yesterday, is allowing New York City to have indoor dining to resume on September 30th with 25% occupancy. So now all phases are still in phase 4 of reopening, which includes higher ed, pre-K to grade 12 schools, and other activities as noted here. And with New York City having the specifications on indoor dining as noted on this slide, face coverings, of course, when not seated, and tables being more than 6 feet apart as elsewhere. Additionally, however, temperature checks will be required, contact information with at least one individual in the party seated for contact tracing should there be any positive cases in the vicinity, no bar service, the restaurants will close at 12 a.m., recommendations to limit air recirculation and enhance air filtration and ventilation, and to continue outdoor dining. The case counts in New York City will be reassessed on November 1st, and if there's no significant increase, capacity for indoor dining will increase to 50%. Again, the regional dashboards, just to show these very quickly, these are similar to those already showed in the statewide trends. However, just note that you can go to these sites to look for your region's numbers and rates. So you can see here, for example, we see the continued statewide high testing counts and low percent positivity. However, you can go to your region and note, for instance, look here on the slide at the bottom line, Western New York has upticked a bit to 1.5% positivity. As that uptake started to occur, it was identified that there were some clusters related to workplace locations with close workplace contact, such as on farms or in manufacturing type settings. And so those were aggressively addressed with multiple rapid testing sites opened and multiple more tests obtained that were targeting at potentially exposed individuals to try to contain any clusters. And so that rate that's a bit higher, maybe reflective of that, and we'll continue to keep an eye on that. And we see some upticks as well in the Mid-Hudson region, where we also know that there are college and university clusters and Long Island that may be impacting those rates. And again, testing increasing in that area to contain any college or university clusters, as well as contain spread in the local community there. As many may have heard, SUNY Oneonta was our first college university in New York State that had to close down after early on there were social gatherings with students leading to large numbers of cases, and initially they went remote and then closed for the semester. We see here the early warning monitoring dashboard, again by region available, and this gives you the rate, again, just to look so that you can see what the rate is for the region per 100,000 individuals on a 7-day rolling average. And again, we're maintaining that rate. And again, we will keep an eye on that daily hospitalization rate, but again, that is maintaining at a low rate. So now some brief updates on schools. So pre-K to grade 12 reopening, as many are aware, is occurring this week throughout the state. Each school district has plans for in-person, hybrid, or remote learning, and that often varies based on the rates in the community as well as the different plans for different age groupings and grades and different settings and different needs, such as special education needs. So a couple of the important themes that are consistent throughout all the school districts are that children, teachers, and staff members will be screened prior to entry into schools. And if there are any symptoms consistent with COVID-19, they are not allowed to enter the school building, or if they're already in the building, they will be immediately isolated and sent home. They will be advised to seek care with their healthcare providers. So many of you are aware to expect these calls, many of which may have already started over the last couple days. And important to remember that telemedicine is an option here, as it has been throughout this pandemic, including telephonic visits when appropriate. COVID testing, of course, is recommended for any COVID-related symptoms or COVID potential symptoms, including, even mild upper respiratory symptoms, cough, GI symptoms, etc. And that, of course, while those tests are pending, those students cannot go to school. They will have to be isolated at home and excluded from school until that test result is back. And of course, engaging with the local health department for any concerning cases, highly suspect cases, or test positive cases on any students. And to assist communities in understanding the level of cases in their school communities, a school survey has been initiated, and a dashboard will shortly be available at this link here, schoolcovidreportcard.health.ny.gov. And I'll show you some further information on that in a slide or two. At the bottom of the slide here, you'll see the web page for the New York State Department of Health COVID Schools website. As any guidance comes out over this reopening period, guidance will be updated and posted there over the next days to come. So again, this is listed here as a resource for you as healthcare providers to assist your patients, particularly those who are affiliated with schools or colleges who may be seeking testing, and where to find a test near them. And also the hotline and the online screening tool for how they can sign up for any of the state-sponsored testing. And again, this link for the website with the turnaround times. A little more on the school report card dashboard. So what data will be available and what is the purpose of this survey that schools will be filling out? The aim is to have data available on a dashboard for healthcare providers to understand and community members to be able to view the positive cases over time, and students and staff by school and school district, and whether the school or district and student and staff are remote, in person, or hybrid, the number of students and staff on site, and the percentage of those on-site students and staff who test positive. And if the school or school-based health center is doing any testing, any of those tests administered by the school, what the test type is, the laboratory used, and any of that information will be available on those percent positive of those tests administered by the school. All of that information, the school information from those school surveys, the lab data that healthcare providers now must provide the labs with information that will then reach the local health departments and the New York State Department of Health, and local health department input on clusters in their communities related to schools. All of that will be pulled together at the New York State Department of Health, and this information will be available in a dashboard. The dashboard will look like this. There'll be an area where you can search your address or city, as done here with this example. This is purely an example. And then we see here on top will be the school district numbers, and below the schools within that district number if it's a school district. And then some further information on testing positive, teaching model, COVID testing if it's performed there, and total and positives. And some of these further details with positive cases over time, percent of the school that's tested positive, and then again, the testing summary if the school does administer testing, and enrollment and employment data. Now for some brief updates on COVID vaccine. There's been some progress in this realm, and there has been a lot of discussion in the lay press and in the political sphere about this at the federal level. So just to cover some of these updates that are important for you as healthcare providers to be aware of, as your community members and patients might ask you kind of what is all this about. So just to review briefly the COVID vaccine updates. So currently in the U.S., our top vaccine candidates are the Moderna, which is sponsored by the NIAID, the NIH, and the Pfizer vaccine candidates, which both had entered phase 3 trials late in July, on July 27th, with plans to enroll 30,000 people each at multiple sites throughout the country and even globally. Both are a 2-dose series that would require 2 doses separated by about a month. And both use messenger RNA technology vaccine platforms, which is a novel vaccine platform. There are no other current mRNA vaccines in current use. And of course, phase 3 is where we will have our larger number trials to really understand in larger numbers safety and really understand efficacy, as prior published literature really looked at antibody response, but not actual efficacy and protection to disease. So this phase 3 trial results are really essential before proceeding any further. White House comments were made about the potential rollout of either of these vaccines prior to November. However, would just like to share that experts in the field do feel that it's extremely unlikely to have results by early November. With the start of these trials July 27th, the need to enroll 30,000 people separated, 2 doses separated by 1 month, and then track outcomes. Even if incredibly efficacious, experts feel it likely will be a 5 to 7 month time period before results are available. Other important updates just from over the last couple days are that AstraZeneca's vaccine, which is the third farthest along in the U.S., announced that they had to put their vaccine phase 3 clinical trial on hold for a safety assessment due to a severe illness in a vaccinated participant. The participant had transverse myelitis. It has not been determined that the vaccine is the cause, but this is under investigation. This is not apparently an unusual process during vaccine trials with thousands of individuals entered, that there might be a serious event that needs to be investigated. However, it is important to note this and be aware of this as we discuss these vaccines moving forward. This is a different type of vaccine. This is not the messenger RNA platform. However, it's a chimpanzee adenovirus vector. Amid all of this, there has been a pledge on the 8th with CEOs of 9 vaccine-producing pharmaceutical companies to continue to make the safety and well-being of vaccinated individuals a top priority in development of the first COVID vaccines. Some other federal COVID vaccine updates. There have been some updates in the realm of distribution amendments coming through the federal side. So just yesterday, the Department of Health and Human Services issued an amendment to the federal COVID emergency declaration, allowing licensed pharmacists to administer FDA-licensed or FDA-authorized COVID vaccine to children and adults 3 years of age and older. This follows a late August amendment for pharmacists to administer any FDA-licensed and ACIP-recommended vaccine to children ages 3 to 18 years. And New York State specific guidance on these federal amendments are pending. It's important to note that we here in New York have established that before any vaccine would be recommended, the New York State DOH will be reviewing the vaccine studies and other information along with other independent advisory boards and organizations to review any of that vaccine information before making any recommendations. With that said, while we wait, it is essential for healthcare providers, particularly healthcare providers of adults and folks who are elderly, to be proactive. Although we are not expecting this vaccine imminently, we need to start right now imminently to prepare for the rollout. And that includes being proactive and getting set up in our New York State Immunization Information System, or NICIS. And for those in New York City, that's the CIR, or Citywide Immunization Service. System, I apologize, and to engage with NICIS and CIR to get set up. We know that the the coverage among pediatricians who typically vaccinate regularly is quite good. However, among adult and elderly providers, please engage with NICES and complete this survey so that if you are a provider located in New York State, here's the survey link. If you're outside of New York City and you're interested in administering COVID vaccine when it becomes available, or if you're currently interested in receiving supplemental publicly funded seasonal influenza vaccine for adults, please fill out that survey so that you can be linked to NICES and engage with NICES, where rollout would be occurring in the future for COVID vaccine and currently for adults influenza vaccine. The email address with any questions is here. And of course, here at the State Health Department, we're engaged in vaccine allocation scenarios along with the CDC and other independent partner advisory groups to ensure that we are planning for all potential scenarios. Influenza vaccine updates. Reminder that PPE for vaccine administration is similar to PPE for routine healthcare. So screening patients first for symptoms consistent of COVID-19, and then a medical face mask for healthcare workers, not a cloth face mask like for the public going to the supermarket, but rather a medical face mask, as the aim is to also protect the healthcare worker, and eye protection, face shield or goggles for those communities with moderate or sustained transmission, and CDC recommends it optional for those with minimal, with none to minimal transmission in the community. So eye protection, face shield or goggles, and of course, if using gloves, hand hygiene before and after. Remember that healthcare provider recommendations for influenza make a difference. Even if you don't administer flu vaccine in your practice setting, a recommendation can positively impact your patient's likelihood of getting vaccinated. You can refer them to a pharmacy or to another testing location. And we've had a lot of questions about school-related mandatory vaccines. So for those pre-K to grade 12 mandatory school vaccine requirements, those are still in effect, still 14 days after the start of instruction, and that is whether that individual school or that individual patient is remote or in-person or hybrid learning. Those requirements are still in place. Post-secondary students and college, in-person or hybrid, if there's any on-site instruction, again, the mandatory immunizations are still required. For the post-secondary students, however, remote only, those immunizations are not required. Of course, they are recommended. Here along the line of COVID vaccine updates, again, is a link here on this slide for the COVID Prevention Network website, which details all of the vaccine trials throughout the U.S. and many in New York State. So if folks are interested in engaging in a vaccine trial, please send them to this website where they can sign up. And now we'll hear from Dr. Marcus Friedrich, Chief Medical Officer in the Office of Quality and Patient Safety here at the State Health Department.
Thank you, Liz. Hi, everyone, and thanks for joining this afternoon. I just want to pick up, Liz, where you left off, especially on the vaccine. We did a webinar 3 weeks ago on 8/13, where Betsy Rausch-Fung, one of the physicians here from the Bureau of Immunization, gave a really great overview about the mandated school vaccine. So if you go back and look for that on our website, this is probably very useful to get an update on especially the school vaccines. And I also wanted just to briefly talk about two issues. Again, the travel advisory. As you know, these recommendations and that changes frequently. Just yesterday, 4 states were added to the list: Maryland, Delaware, Ohio, and West Virginia, and 2 states were removed. The total still remains 35 states. I would urge everybody, if there are questions, there is still, Liz mentioned that a couple times, coronavirus.health.ny.gov. There is a link on the website in the middle for the travel advisory. I usually go through Google and just type in New York State Travel Advisory, and it pops up. And that gives you the latest list of the states where this travel advisory is recommended. Overall, I just want to mention again the 2 rules, what the state qualifies to be on this list as a positive test rate bigger than 10 per 100,000 over the 7-day rolling average, and or a testing positivity rate of higher than 10% over a 7-day rolling average. The positivity, as you've seen on one of Liz's slide here in New York, overall is under 1%, and it's below there for a month now, which is really, really amazing. We had 63,000 tests and only 576 positive yesterday, but there are regions where it's slowly picking up, and we at the Department of Health are keeping a close eye on that, especially Western New York, Mid-Hudson Valley, and Long Island, where there have been a couple of days where it's over 1%. So we will keep an eye on that. And second, I just want to talk again about the preparation for the fall here at the State Department of Health, especially in view of COVID and or like co-infection with flu. There was the new executive order that Liz mentioned, which I just want to remind everybody this immediate reporting is very, very important because the two main pillars of our strategy and why we've been successful over the summer is one, the testing and having the testing capacity, also being now expanded to schools and colleges, but also the tracing. And the faster the tracing team can get the information, the faster they can get to the people and hopefully quarantine the people before they infect other people down the road. The third pillar is really like thinking about capacity, pre-hospital, hospital, and post-hospital. This is of course like a concern for the department, but I think we worked in the past with our partners in the hospital associations and the hospitals to really get ready if there is an uptick in cases. The fourth is medical supplies, and this really talks to PPE and ventilators, making sure that we have enough material here from the state to keep not only the healthcare providers but also our patients safe, and then making sure that ventilators are functional, that they can be deployed very fast to institutions who are running low on ventilators and so forth. So that is a lot of activity in those fields. And then the fifth is personnel, making sure that we here at the State Health Department keep an eye on the development and also deploy personnel if needed in these different areas. And then of course overarching is data, making sure that we have actionable data. I'm very impressed with the school dashboard. You can send your patients to that. I know there are a lot of concerns, parents out there, and just making sure that their kids and the school and especially the school districts are safe. With that, Liz, I want to give it back to you.
Great. Thank you so much. So we know this has been a long road for everyone, for all of us in healthcare, as well as for our patients and communities. So we welcome quick tips for clinician well-being in the era of COVID-19 by Dr. Louis Nitkoff.
Thank you, Liz, and good afternoon, everyone. Welcome to the next installment of Preparing for Fall in the Face of COVID-19. I'll start with a reminder for all prescribers in New York State that the 3-year renewal of mandatory prescriber education for palliative care, pain management, and addiction is due by October 1st, 2020. I've given the link here to the department website that has guidance regarding this. The deadline was postponed from July 1st to October 1st due to COVID, and if you completed the program in 2017, then you're due to complete it again this year. So there are different approaches to planning ahead. There's the folklore approach of Yogi Berra. It's tough to make predictions, especially about the future. There's the philosophical approach from the Roman philosopher Seneca. Luck is what happens when preparation meets opportunity. The scientific approach of Louis Pasteur, luck favors the prepared mind. And then there may be a reality that intervenes, and as Dr. Trappy from University of Minnesota recently wrote in JAMA, I'm too exhausted by the events of the summer to think about what the fall or the winter will bring, so I don't. I include that quote not to depict him in any negative light, but to emphasize the enormity of what we've all been through over the last several months. Nonetheless, we know that the fall is coming, and we really do need to think about beyond summer. We start really by thinking about where we are now, and we know that there are marked geographical variations in COVID incidence and prevalence throughout the country, and these variations make it difficult to characterize waves or phases. So if we look at the national picture, we're probably still in phase 1. But if we look at New York, it's clear that we are in a very different place than we were a few months ago. In addition, there have been some well-publicized super spreader events, including the motorcycle rally in Sturgis, South Dakota, that was attended by more than 400,000 people and has now been attributed to causing more than 260,000 cases across the country. There continues to be much uncertainty. We know the uncertainty will be with us for some time. There's uncertainty about coexistence of influenza in the fall and what impact that will have on resources, the duration of immunity to COVID, the duration of illness itself, and recently the few cases that have emerged of serologically and virologically confirmed reinfection. The Infectious Diseases Society of America has identified a number of critical issues for consideration. These are taken from their recommendations that were published in June of 2020, which will probably be updated in the not-too-distant future. I'll be addressing some of these this afternoon, but not all of them. So, thinking about PPE and medical supplies, we know that there are ongoing shortages of N95 respirators necessitating reuse and extended use. The American Nursing Association conducted a survey and has done multiple surveys. The most recent one, which was at the end of the summer, or late August actually, of more than 21,000 respondents, and they indicated that the percentage of reuse and the extended duration of reuse both increased from the survey that was conducted in May. This, of course, is a source of stress and anxiety for healthcare workers. The professional societies, including the Medical Society of the State of New York, have procurement programs for their members that can be helpful. There's also an organization called GetUsPPE.org, which provides donated PPE at no cost to frontline workers, undersourced and under-resourced communities with a sense of urgency and a focus on equity. The PPE issue is probably also exacerbated by the resumption of elective procedures throughout the country and the lack of consistent evidence-based guidelines from medical experts and organizations regarding the use of PPE. On the therapeutic front, the only approved medication for COVID under an emergency use authorization is remdesivir, and there are concerns about cost and supply. Corticosteroids have also been used off-label, and there may be other medications in the pipeline. From the standpoint of testing, there is still no national strategy for testing. Estimates are that to have a robust national testing strategy, we need at least 1.25 million tests per day. This was a recommendation of the Kaiser Family Foundation. At best, we're currently at about 800 to 900,000, but it's remarkable to note that about 10% of that number is actually being carried out every day in New York State. Now, there are ongoing concerns about availability, accuracy, equitable distribution of tests, the sensitivity and specificity of different methodologies, and the need to develop alternative specimen sources, alternative media, and alternative testing devices. There have also been concerns about turnaround time, where if it's longer than a couple of days, it really reduces the utility of testing and having that information in a timely fashion. With respect to contact tracing, there continue to be challenges regarding funding and sufficient workforce. There's also a lack of engagement on the part of the population of individuals who have been infected or exposed, perhaps due to lack of trust of the public health system, and this is an educational challenge for us. And there are also challenges regarding coordination across state lines because, again, there's not a national strategy for contact tracing. We know that data and data collection are incredibly important. Collection and reporting need to be uniform and rigorous, which is not currently the case. Data need to be granular so that they're actionable. It's important to include race and ethnicity by zip code because of the disparities in morbidity and mortality associated with COVID. And along with attributed hospitalizations and deaths, we need to look at excess hospitalizations and excess diagnoses of pneumonia in order to fully understand the scope of the pandemic. We've talked in the past about social behavior, and these are, of course, the usual suspects: masks and face coverings, physical distancing, evidence-based reopening that really affects every aspect of our society, our social institution, religious institution, restaurants, retail, museums, gyms, schools, which, of course, have had some starts and stops with regard to reopening. Mindfulness regarding the size of gatherings, and the need to continually monitor and reassess the consequences of reopening, along with a willingness to recalibrate and backtrack if necessary, as painful as unpopular as that might be. The final thing I want to touch on is preparing for a COVID-19 vaccine. There's certainly been a lot of publicity about this recently in the lay press and the medical literature. And the primary concerns, of course, are safety, efficacy, and timing. But a very important concern is public acceptance, because vaccines don't prevent infection. Vaccinations do. A researcher from the University of Pennsylvania recently published in the Annals of Internal Medicine a survey of about 1,000 recipients, and 58% indicated that they would accept a COVID vaccine. About 32% were unsure, and 10 or 11% said no. The factors that influenced individuals' response toward the negative included younger age, black race, limited level of education, and a history of recently refusing flu vaccinations. Those in the unsure group wanted more information and indicated that there was some lack of trust due to lack of information. And of course, there's the issue of anti-vaccine bias, which already exists in our society. There's also concern that the yes group may be an overestimate based upon recent uptake of flu vaccines during flu seasons over the past few years. From a public health perspective, the effectiveness of vaccination has really to do with the relationship between efficacy and uptake. So that if a vaccine is 50% effective and there's 80% uptake, it really has the same public health benefit as a vaccine that has 80% efficacy and 50% uptake. Both of those scenarios would be expected to yield about 40% protection. So certainly more to come on vaccines. So when we convene again in our next session, I'll be covering some specific strategies for planning in a time of rapid change. Thank you for your attention today, and as always, we welcome your suggestions and feedback. Back to you, Liz.
Thank you very much, Dr. Snitkoff. Now we'll just highlight that the rest of the slides here are available for you as resources, including the peer-to-peer program through MISNI. The information is available here, a COVID well-being webinar that you can use for your practice or yourself, and some information on healthcare provider and healthcare worker wellness, where to text if you need support for your patients and community, the mental health helpline, other resources and web pages that are of value, and information on telehealth. Our healthcare provider compilation will be updated over the next couple days and will be available on the web page here, as it's routinely available on that site. And then again, these mirror clings for your practices or to recommend to businesses in your communities. As we reopen, we really want to keep emphasizing all of these hand washing, proper face mask wearing, screening at entry, and all of these other issues. So now we'll go on to a question and answer session. Marcus, would you like to start?
Yeah, Liz. So the first question is a question that we have mulled around here over the last couple of months. It's this weird thing about the test that people can stay positive for quite some time. So how should a patient who have had COVID, who continue to test positive many weeks later, be handled? Can DOH release guidance in this area? Can you comment on that?
Yes, absolutely. So we do have guidance on this, and maybe we can add that to our next webinar to reiterate again, so that we do recommend that a symptom-based or a time-based strategy may be used. There's one exception to that. That's hospitalized nursing home residents have repeat testing until they're negative before reentry into the nursing home. However, for all other individuals, the approach is really that individuals are on isolation after a positive test for at least 10 days after symptom onset. If they were asymptomatic and tested based on exposure, for instance, or another reason for testing, if they were asymptomatic, then it's from that date of that specimen collection. So at least 10 days from symptom onset or date of specimen collection and symptoms improving, and at least that time period of 72 hours without any fever, without the use of fever-reducing medications. And then those individuals would be released from isolation from their local health department. It's really the local health department that initiates and has the public health authority to isolate and quarantine, and then to release that isolation and quarantine. So if you as a healthcare provider or a school nurse has any questions about that, you call the local health department, and they should be able to communicate with you about the release if that individual has completed their time. And so now I'll ask a question that we received in our inbox to you, Marcus. Does a student on clinical rotation require a mandatory 14-day quarantine, or can he or she test out and return to rotation with a negative test and no symptoms?
Thank you, Liz. This is a little, and I kind of want to answer that in two parts. One is, if the student on clinical rotation, as you know, New York State is a net educator for many, many students from around the United States and out of the United States. And it's really a question if a student is an essential worker or not. I just want to make sure that people understand the distinction. There is an FAQ, a frequently asked question, on the New York State Travel Advisory side that tries to start to answering the question. Like for all essential worker, usually 14 days quarantine is warranted, but there is this exception that entities, meaning like healthcare systems or physician offices, can allow the healthcare workers to work if all of the following is true. And it starts with that furloughing an adverse, that furloughing the worker would have an adverse impact on the healthcare setting, that the patient is asymptomatic, that diagnostic testing within 24 hours when they arrive in New York is being done, that they self-monitor, that they wear a face mask while working, that they are assigned to lower risk patients, that they are self-quarantined when not at work, and if they have symptoms, that they stop immediately, isolate at home, and get a COVID test. So I would argue that like a medical student would be an essential worker and therefore needs to adhere to all these. So if there is a student on a clinical rotation coming from a state that is a high impact state, I would make sure that he gets tested, and if he's negative, that he can start his rotation here. The other question, if a medical medical student had exposure from within, like in his family or through his friends. And I again would use the essential worker guideline that the patient needs to be tested, that if there are no symptoms, that that the practice or hospital can allow the patient with the face mask, if they stay asymptomatic and have the diagnostic testing within the 24 hours, that can help the student to fulfill the clinical rotation without being automatically on 14 days quarantine.
Thank you.
I have a question for you, Liz. Maybe that's the last question. Please advise if children who have COVID-19 positive tests can return to school after 10 days if they have no fever, but still are with a cough, cold, or a runny nose.
Yeah, good question. This is certainly going to come up, both COVID positive tests with a cough, cold, and runny nose, or COVID negative tests. So we know that those cough, cold, and runny noses will not quickly be completely resolved. So just to review, if the COVID test is positive, again, that at least 10 days from the symptom onset, or if they were asymptomatic, the time of that test specimen collection, at least 10 days, at least 72 hours with no fever, without fever-reducing medicines, and symptoms improving. And then folks would be released generally from isolation at that point by the local health department. But the key thing is that the schools should be checking with the local health department for that release from isolation. And then that individual can return to school. If they have a cough, cold, or runny nose, and they're tested and they're COVID negative, again, the negative and they would have had a consultation with their healthcare provider, been tested, they are negative. That cough cold will likely not be resolved or completed, but they have that negative test. And that should suffice, a negative diagnostic test with a note from the healthcare provider to allow them back into school, so long as public health or the healthcare provider does not feel that they're a high-risk individual who needs any additional testing if they were tested with a rapid antigen test. So if it was a rapid antigen test, there may be circumstances of high concern to either the healthcare provider based on symptoms, or to the public health based on community epidemiology or possible exposures. And in those cases, if public health or the healthcare provider would recommends a molecular test after a negative rapid antigen, then they should get that molecular test and stay in isolation until that is back. Otherwise, if they're not high risk, the negative antigen test or the negative of both, and then the child would be able to return to school with a note from the physician. However, they must, of course, not have fever per routine school guidance. So in that scenario, no fever for 24 hours without fever-reducing medicines, just as per routine guidance, and then they would be able to return to school.
So that was it. Again, I want to thank all of you for listening in today. We will try to continue this through the fall, at least every 2 weeks. And we are also debating if there are urgent new developments that we would maybe increase the frequency to weekly, but that is being debated right now. So thank you again, all what you're doing. Hopefully you have a good fall. And with that, have a good rest of the day.
Thank you very much.